It's time to focus on seniors with Helping Seniors TV. The television show designed to make you aware of senior issues and needs, as well as to acquaint you with the resources available to help you age in place and with dignity. Now, here's your host, Joe Steckler.
I'm Joe Steckler, and welcome to Helping Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is glaucoma and cataracts. And joining me is Dr. James McManus of the Eye Institute. Welcome, Dr. McManus.
Thanks, Joe.
It's nice to have you here.
Oh, it's good to be here.
It's been a long time.
It's been a few years since we talked. Yes, it has.
But it makes me appreciate, Doctor, the fact that I started this organization in July of 2011. And I had a foundation the other day say to us that they were thinking about denying funding because of organizational stability. And, you know, it kind of tickled me to think that we've helped over 900 families while operating on an extremely low budget. And your doctors at the Eye Institute have supported us from the very beginning.
Well, we're glad to do it. I'll tell you that.
Well, I think that you all recognize that it's more than a publicity factor. It's getting good information out to seniors and those that care for seniors. And here in Brevard County, we have a county of 540,000 people, over 25%, over 50% qualify as seniors. A lot of people don't know that.
Wow, those are impressive statistics.
That is an impressive statistic. Furthermore, there are between 67,000 and 75,000 veterans. And then when we add spouses and families of veterans, we add thousands more to the equation. And we're finding through the production of our shows, our radio, TV, and articles, that there are so many people that qualify for VA benefits that don't even know about it. And in the process, they're living as uneducated people on $700, $800, and $900 a month of food stamps.
Wow.
That's horrible.
It is.
You take that same thing and translate that to the topic of today's show, glaucoma and cataracts. And before the show, I ask you a couple of questions, and we'll probably get into that as we develop our show. But let's take it two-part. Let's talk about glaucoma first, and then we'll talk about cataracts. I don't have glaucoma, I don't think, but I do have cataracts. So I'm got kind of, when you talk about cutting on the eyes with cataracts, I'm more in tune with that. Glaucoma, I'm not. Glaucoma, though, I think is probably one of the least diagnosed or maybe misdiagnosed or failed to be diagnosed conditions of the eye. Am I correct or not?
You are. It's estimated that approximately half of the people who have glaucoma in the United States probably don't know it. That's how underdiagnosed glaucoma is.
I've heard it said that glaucoma is one of the most deadly of all eye diseases for the very reason that you just said.
It is. The reason is that glaucoma is what we call a silent disease. And what happens over time is that a pressure inside your eye that you cannot feel eats away at your nerve until eventually it causes blindness. The good news is that we can nowadays, with new technology, determine those patients who are at high risk for developing glaucoma long before they have any problems with their vision.
How do they do that?
Well, the first thing is usually the patient will have a screening exam. And sometimes it's the primary care doctor who will mention to a patient that it'd be good to have their pressure checked in their eye. Sometimes it's an optometrist who refers a patient to us. Sometimes it's another family member who will remind someone that they have a family history of glaucoma. And then the patient will come in and we'll check their pressure. We'll look at the nerve in their eye because that's where the damage in glaucoma occurs. And then if we feel it's justified, we'll then go ahead and do further testing. The good news is that we have all the instruments to do the testing in our offices, and the testing's painless.
Is that the puff on the eye?
Well, the puff is actually an older technology. We usually don't use that anymore because it's not as sensitive as the newer technology for determining pressure. But that's the way the screenings are done, and it's a very good way in picking up some of the patients who do have a likelihood of developing glaucoma.
How do you, if the puff on the eye was the older technology, how has the industry progressed so that the tests are more definitive?
Well, there are different tests that are available. The gold, what we call the gold standard, would be something called the Goldman tonometer, where an instrument basically floats on the tear film and measures the pressure inside the eye. And it does it by using prisms, and that's how we check the pressure most of the time. There are also other ways of treating the pressure using handheld devices. And we'll do that, for example, if we're doing a laser procedure on a patient or if we're doing a screening, that sort of thing.
You mentioned laser. How do you use the laser? Use the laser to test for glaucoma or treat?
Treat. We treat for glaucoma. Generally, we'll start, the patients who have the greatest likelihood of having damage and glaucoma will start on eye drops. And depending upon their ability to tolerate the drops and the success in lowering the pressure, that will determine whether or not we have to go on to other stages of therapy. And the next stage would be laser therapy.
Okay. Let's come to a dead halt, and let's help those people on the other side of this camera. First of all, what is glaucoma? What is it?
Glaucoma is a disease in which pressure inside the eye damages the nerve, and when it damages the nerve, it leads to problems with the peripheral vision, so that a person will eventually lose the ability to see out in their side vision. Once that happens, there's permanent damage. Our goal is to determine those patients who are likely to have that damage before it actually occurs. Now, in the old days, unfortunately, patients would go undiagnosed for long periods of time. But the good news is nowadays, most patients are getting screened, so we're detecting a lot more patients who have early glaucoma long before they have substantial damage.
Okay. Now, who all does, you all have the Eye Institute, and at the Eye Institute, you got all kinds of specialists.
Yes.
But if you go to a place like that makes the glasses, Sears, Walmart, all these places, and they say they have an eye doctor there. That doctor, what does that doctor do different than what you all do at the Eye Institute? What's the correlation or the uncorrelation?
Well, the doctors who are at a place like Walmart or Pearl Vision or the private practitioners in the area, most of the time those are optometrists. And they're usually very well trained. And what they're doing is they are treating, they're determining the proper prescription for glasses for the patient, but also treating the patients medically for glaucoma and detecting those patients who have a likelihood of developing glaucoma or who are not responding to therapy. We'll get a lot of referrals from those doctors in the community. And
the reason they refer to you is because you all would be more expert, have a different depth of training to treat glaucoma or other disease of the eye. Am I correct?
That's correct. That brings up two issues. We will be able to perform lasers or surgery if that's necessary for glaucoma, but also we generally will be sometimes asked to determine if it's glaucoma or if it's a neurological disease that's causing the problems with the peripheral vision.
Okay. Let's say a person has glaucoma. And you talked about using a laser to treat it. What does a laser do? What are you treating? And are you removing or what are you doing to glaucoma? I don't understand that.
Well, you're not alone. There are a lot of people who really don't understand the laser because the reason is that treatment for glaucoma has changed over the years. In the old days, there was a heat laser that was used to treat glaucoma. And what it did was it basically caused scars inside the drainage canals of the eye.
Okay.
And the theory was by producing those scars that the tissue between the scars would be stretched. It's like any other drain. If you pull on the tissue and open the drain, more fluid goes through and the pressure goes down.
Is that like the tear duct?
Kind of like a tear duct, but not associated with the tears. This is all fluid inside the eye.
Okay.
Nowadays, what the laser does is it's a cold laser that stimulates cells inside the eye, basically to clean out the drains so that more fluid goes through and the pressure goes down. The big difference is that unlike the heat laser that we used to use, which could only be done once, basically in your lifetime, this laser can be repeated. So what that means is that, for example, if you can't tolerate eye drops or the drops are not effective, we can do a laser, and that will usually work for several years. And then if the pressure creeps up again, we can repeat the laser. That's the big advantage of this newer technology.
Well, I go to a chiropractor, and he uses the cold laser on my back. Is that the same theory?
It may be, but I'm not that familiar with lasers that are used outside of the eye.
Well, I know that he's got an adjustment thing, and he looks in the manual and has to tell what settings to use for different parts of the back of the leg. But I would assume the reason I ask a question is because you talked about the cold laser stimulating.
Right.
And I think that's the same thing that the cold laser would do to the back or the nerves and your back to stimulate the nerves.
It might be. In the eye, it's pretty simple. What we're doing is stimulating cells called macrophages, which then remove the breakdown products of cells that are in the drains.
Are you finding that the laser treatment is it good, better, or best in treating glaucoma?
It's a good question. What we have found, actually we did a study on that. We looked at the cost effectiveness of laser versus medication. And what we found is that if a patient used laser instead of having medicine, that they and their insurance provider would be saving tens of thousands of dollars over their lifetime in terms of the cost of their medications.
That's one thing. But how about the effectiveness, or what is the better treatment for, say, halting or stopping glaucoma? Medication or laser? I'm sensing laser is a better treatment.
In general, it is. If you were to look at the effectiveness of laser versus a single medicine, probably laser is going to be better. The reason that we use laser so much nowadays is because many patients will have to be on several medications. And when you're on several medicines, the chance of having a side effect increases dramatically.
Okay, a good question. I don't feel the cold laser.
You can't feel this laser either.
How about the laser that's used on the eye? Do you feel that?
Can't feel that either.
Yeah, when we talk about cataracts, we're going to talk about cut on the eyes.
Okay.
And that's a little bit different. But let's stick with glaucoma, because I know many people that actually have gone blind from glaucoma. And how long ago, doctor, was it that the laser and the medication treatments became known? I'm thinking in terms of people in the 60s that went blind because of glaucoma, but was that something that was just an untreated case?
It's a good question. Until about 2001, what happened was doctors, including ophthalmologists, believed that if the pressure was not excessively high, in other words, if it was less than 21, that was acceptable. Unfortunately, we've learned since then that there are a lot of patients who will continue to show progression even if their pressures are in the low 20s and high teens. So that's why it's important for those patients to be followed regularly, because if we do detect changes in their vision or the function of their peripheral vision, that they'll need lower pressures. So the major change in the philosophy of the treatment is patients who are showing progression need lower pressures, even if their pressure would be considered in the normal range.
Okay. When I go to see a doctor at an eye clinic, I notice the preponderance of patients there are older people. Is this because, well, we have more eye problems as you get older?
That's true.
But is it because the younger people don't know that they need to get their eyes checked? Or is it because they ignore it? Or I can't believe that young people don't have the same eye problems that older people have.
Well, the surprising thing is that the average age of the glaucoma patient is about 53. So when you think about that, that means that half the patients are going to be over 53 and half of them are going to be younger. But you're right. Unfortunately, a lot of the younger patients seem to ignore it. And then they'll come in and they'll already have some damage. The good news is that I've noticed over the years that patients seem to be getting in earlier because their parents or their siblings will tell them to have an evaluation for glaucoma earlier.
What covers the cost of seeing an eye doctor? If you're like I am, Social Security, it covers everything. But are there medical insurance? Does medical insurance cover the cost of seeing a doctor, an eye doctor?
Well, it will cover the medical portion of it. In other words, if you have a suspicion that you have glaucoma because of a family history or because you're African American or Hispanic, those are two other risk factors for glaucoma, then generally your medical insurance will cover it. It's not eye care per se in the sense of glasses and refractions and or contact lenses. This is specifically to treat medical conditions of the eye.
Okay, you just mentioned a key thing. We're going to talk about one more thing, and then we're going to shift over to cataracts. But you just mentioned Blacks and Spanish as having being at a higher risk factor than, say, a Caucasian person would for glaucoma?
That's correct.
Then, since I'm going to be doing a feature column in Aldea today, the Spanish community, then I'll ask you to help me write an article on the importance of the Spanish people getting their eyes checked.
Sure.
This is what comes out of of these conversations and talking. We find out things that other parts of the population need to have a better understanding. They simply don't. And so with the access we have through our television, our radio, and all the printed publications we're in, we reach hundreds of thousands of people on a daily basis. People just don't understand that yet. They will once we get through. Right. They're going to understand it. But let's talk for a minute about cataract surgery, because I hope I'm never really familiar with glaucoma, but I am familiar with cataracts. What is a cataract?
A cataract is just a clouding of the human lens. The lens is right behind your pupil, and what happens as the years go by, the lens, which was clear when you were a baby, gradually becomes more cloudy. It'll start out becoming a little bit yellow and then brown, and in severe cases will actually be black in color. So you can imagine if you're trying to look through a window that is at first a little bit hazy and then eventually is opaque, how difficult it would be to see through the window. Same thing's true with your lens. The human lens, when it becomes cloudy, prevents you from seeing clearly.
So when you described a cataract, the next question is, when should a patient be considering surgery for cataract? At what point in this whole process you start thinking about letting somebody cut on your eye?
Good question. Nowadays, when we talk about cataract surgery, what we are telling patients is long before they need surgery, we can actually detect the presence of the cataract. So some patients will go home and they'll talk to their family and they'll say, well, I don't understand why the doctor told me that because I'm seeing just fine. The reality is we can detect the cataracts long before the patient will need surgery. And what we'll tell each patient is this: if you're happy with your vision, if you can drive, if you can read all the things that you want to, if you're not having any difficulty seeing signs like when you're driving, that sort of thing, if you're not having glare when you're driving, you don't need surgery. But when it gets to the point where you feel that your vision is interfering with your lifestyle so that you're not driving at night anymore, for example, or you're not reading as much as you want to, that's the time to think about having cataract surgery.
Which leads me to question number 3.
Okay.
What are the conditions that could delay or prevent surgery?
Well, the first condition that may delay surgery would be someone who has multiple medical problems and they're just not stable enough. For example, if you just had a heart attack or a stroke, or your doctor just feels that you're not stable at this point. But once the patient is medically stable, then we can proceed with cataract surgery. Another consideration would be that a patient just hasn't made a decision as to what type of technology they want to have for their cataract surgery. And so it'd be best just to wait before you can make a good decision and then decide about the surgery.
What are some of the conditions on the eye itself or the retina or the lens or coverings on the lens that could cause a problem? Let's say if you have a cataract and you have a surgery and something happens where you can't see out of the eye. Sometimes does it necessitate a replacement of a lens?
Yes. When you have the cataract surgery, since the human lens or the cloudy portion of the lens is removed, almost every person who has cataract surgery will have an implant or an intraocular lens.
Okay. Intraocular lens?
Yes.
What is that?
It's a small lens that goes behind your pupil. And what it does is it focuses the light that the human lens originally was focusing. The good news is that nowadays, with our technology, we can predict the power of the lens so that in many cases, we can make it so the patient doesn't need to wear glasses most of the time. And I clarify that by saying to the patient, it doesn't mean you're going to throw your glasses away. What it means is that in a lot of the situations where you used to have to wear glasses, you can now see pretty clearly without your glasses on.
But you say you might still need glasses.
Yes, that's true of almost every lens that we implant, even what we call the premium lenses.
I want to ask you a couple of tough questions, and maybe they may not be fair, but I'm sure a lot of viewers have the same question that I do. When we talk about eye surgery, it's a very fearsome thing. You go to a dentist, like I tell all the dentists I have, you are the greatest inflictors of pain known to mankind. You can inflict pain whether you want to or not. But when you deal with surgery, when somebody cuts on a body, like I had a dissecting ascending and descending aorta all the way down my stomach, split completely open. I lived through that. And the only reason I think I lived through it is because God had another reason for me to live through that.
Right. Because
most people don't live through it. And then 6 years later, I suffered a stroke. And I had a little weakness on my left side, and I have to watch my verbiage sometimes to make sure I don't slur my words. But outside of that, my brain has been good. The fact that I'm getting older, more of my body parts are starting to have problems. I have problems with my eyes. I have problems with fibromyalgia. But that doesn't mean that doesn't stop me from talking about myself so that a viewer can say, Joe's experiencing that, or Joe feels that. I wonder how I would feel if I talked about going in to have a cataract removed from my eye. So my question to you as a doctor is that, how do you reassure somebody? Because if gosh, I'm trying to think. Dr. Mandisi.
Yes.
When he did a show with me, when they had that eyeball, I wish I had told you to bring that thing because he can show exactly what you're doing to the eye when you remove a cataract. Can you describe to the people what you're doing? Because we're talking about cutting on the eye, right?
Yes, we are.
And when you read these horror stories, they're talking about somebody hitting somebody in the eye with a thing and the fluid coming out of the eye. Once that happens, you can't fix that.
Well, it depends. I've done a lot of trauma surgery over the years. If you repair the eye quickly and restore the shape of the eye, then as long as there's no permanent injury to, for example, the nerve or the retina, then generally the eye can heal dramatically over the years. And now it may require multiple operations if you have a serious injury. Cataract surgery, on the other hand, is a planned operation. So we make very small incisions for the surgery. That's also true of when Dr. Vashnow, for example, does retina surgery. The incisions are incredibly small.
We're going to talk about that.
That's right. And when a patient asks, how big is the incision? What I do, and I will tell them, just think of a dime. Think of the picture of FDR on the dime and see how big his ear is. That's the size of the incision.
It's pretty small.
It's tiny.
When you do this, do you use these great big bug eyes that you can really see what you're doing?
Actually, we use a microscope with very, very high magnification.
Wow. Are you saying to me that I really should be more concerned about having clear vision than I am worried about whether I would lose my sight through having cataracts removed?
In general, that's true. If you've reached the point where you feel that you're having problems seeing and it's interfering with the things that you enjoy doing, then the next consideration would be having cataract surgery.
If you have the we got a minute and a half left.
Okay.
If you have cataract surgery, and is it sort of a standard thing to replace a lens when you do that surgery?
It is. Nowadays, there are more choices. For example, if you have astigmatism, we can correct for most of the astigmatism when you have surgery. There are different techniques for that. And what that means is that if we correct for the astigmatism, that you don't have to wear as strong a prescription for glasses, and you get to see more things without your glasses on. There are also lenses that allow you to see distance and near. So in many cases, you could see most of the things out in the distance and read using the same lens without putting on glasses. The other technology that we have is a lens that allows you to see distance and intermediate. So you can see your cell phone, you can see what's on the shelves when you're shopping, see your dashboard, and also see at the distance as well. So this is the evolution of the technology.
My last question is, how do you numb the eye so you don't feel the surgery? You only got a quick time to tell me.
Okay. Generally, we use a gel that numbs the eye. But for those patients who are very anxious, we can actually inject medicine around the eye to basically prevent you from feeling most of anything. And we also give sedation. We give Versed so that the patient is relaxed. They can hear what's going on in the room, but they're relaxed and sedated at the same time.
Well, if you work on my eyes, you're going to need a lot to make me relax, because I am really anxious about this, but I'm going to tell you, I have thoroughly enjoyed doing this show with you on glaucoma and cataract surgery.
Very good.
I'm Joe Steckler. Thank you for joining our program today. I'd like to remind you that our senior information line is available to you at 321-473-7770. There you can get help and direction that could be helpful for your specific situation or circumstances. The work of helping seniors is very important, but we can't do it alone. That is why our sponsors here in Brevard County are so important. I'd like to thank our many area sponsors, businesses and medical providers who support the mission of helping seniors that help us carry the cost of our media efforts. If you'd like to join us either as a business partner or simply donate as an individual, we would welcome your call at 321-473-7770. You are always welcome to visit our website at www.helpingseniorsofbrevard.org. Thanks so much for your help. It does make a difference.